Today's subject is the basal ganglia, one of the major motor pathways along with the cerebellum and the cortical spinal tract. It's complicated, and the name basal ganglia is really a misnomer because it's not a ganglion. Let's look at what you think a ganglion looks like and then compare it to what we're going to be talking about today. We've associated ganglia with these collections of nerve cell bodies outside the central nervous system, such as these dorsal root ganglia along the spinal cord. But today we're going to talk about the basal ganglia in the base of the brain. So now let's look at a model of the basal ganglia principal components before we go to the gross specimens. This fun color-coded brain is useful for orientation to the major players that we're going to be talking about today. The basal ganglia consists of two large nuclei, the caudate and the putamen in brown here, separated by this rainbow-colored internal capsule. Next to it is the large thalamus, and one of the nuclei of this thalamus will be part of the circuitry that we're discussing. Nicely shown on this model is the fact that these rainbow colors represent axons going to and coming from the cerebral cortex in a color-coded fashion. So here you have fibers from the frontal lobe and here fibers from the occipital lobe. A very important point to keep in mind today as we discuss these basal ganglia is that basal ganglia disease is associated with involuntary movements, movements you cannot control. And the key diseases that you can think of are Huntington's disease and Parkinson's disease. Another important point we can make on this model is that basal ganglia disease is manifest on the opposite side of the body, whereas cerebellar disease that we have talked about is manifest usually on the same side of the body. So we have two consultants to the cortical spinal tract coming from these red and orange areas. One is the basal ganglia for involuntary movements, and the other is the cerebellum involved with voluntary movements. And so diseases of the motor system can be categorized as either basal ganglia type diseases, cerebellar type diseases, or motor cortex diseases. Let's go to an animation showing parts of the basal ganglia made in 1998, and it's still the best three-dimensional graphic description that I can show you of the green caudate nucleus, which is part of the basal ganglia as it curves around the blue ventricular system. You can see it curves from the frontal lobe where it is large down into the temporal lobe where it is very, very small. And as it comes down, it can be seen to have a body and a tail and a very large head. So the caudate nucleus curves around and follows the ventricle. This second animation adds the structure called the putamen. The putamen is large and green, and this space here represents where our rainbow internal capsule was located, and here's the caudate that we've already looked at. And now let's introduce another term. The putamen and the caudate together are called the striatum. Now let's rotate this. And you can see the tail of the caudate coming around and the putamen, and we can look through this phantom brain. And by the way, the red structure is the amygdala. In this animation, we're going to peel back the cerebral cortex and look in a coronal view at these structures and another new structure we're going to add called the globus pallidus on the inside of the putamen. So here's the putamen. Watch as we rotate, peel back the cortex, and separate the putamen with its globus pallidus out to the side. This is the globus pallidus. You see how it's tucked into the inside of the putamen? And then we have a new structure up front here. This is part of what's called the ventral striatum or nucleus accumbens. And this is an important area associated with reward-seeking behavior, pleasure, and addiction. Now, let's go to the gross specimens. In this hemisphere, I can show you the caudate very poorly because it's inside and next to the ventricle, as we saw. If this is the corpus callosum, this is the lateral ventricle. This bulge that I'm running my probe over inside the ventricle represents the head of the caudate. Now let's look at a coronal section. This is the first of 4 coronal sections we're going to look at briefly. Just to see the structures, here we have the caudate nucleus with its bulging into the lateral ventricle separated from each other by the septum, pellucidum, and the corpus callosum is above and below. So that's pretty straightforward. Now we're going to look at these structures, and I'm going to turn this over. And as we look at them, we're going to just sort of recognize them, and later we're going to talk a little bit about the circuitry. So on the other side of this, what we see now is the head of the caudate is just this part here. It's getting smaller, and another structure is coming in over on the side. This is that putamen. So together, the putamen and the caudate make up the corpus striatum. Why is it striatum? It's striped. It's striated by these white fibers of the internal capsule, the anterior part of the internal capsule that separate the caudate and the putamen. So now let's look at the next section. Going caudally, now we've added our temporal lobes down here, and this area down here around the junction of the putamen and the caudate is the area called the ventral striatum. This is where that nucleus accumbens is that is so important in reward and pleasurable seeking behaviors. And it's not very clear here, but that's the region where it's located. So on the other side of this same section, we can see now that our caudate nucleus continues to get smaller, and the internal capsule is getting larger. And off to the side, we have our putamen. And now, do you see this paler area, sort of triangular in shape? That is paler than the putamen. That is the globus pallidus, paler, pallidum. All right? And then coming across here, we can see the anterior commissure, and this part of the pallidum that is down beneath the anterior commissure is the ventral pallidum. It works together with the limbic system and that nucleus accumbens. And down here, we see the optic chiasm and temporal lobes. So this section has a nice large temporal lobe. We're moving caudally. The ventricular system, the lateral ventricle, is out here to the side, and here, always in relationship to it, is the caudate nucleus. You see how small it's getting? This is a part of the body, and it's going to get even smaller such that we can hardly see it. Now, between the internal capsule here and the third ventricle in the midline, we have the large thalamus. The thalamus plays a large part in the circuitry that we're going to be discussing later on. So, our players are thalamus, caudate, putamen, and here is our globus pallidus down here. Here is the mammillary body. It's just a landmark for us at this moment. And the last section we're going to look at is back a little farther through the thalamus and the internal capsule. And our basal ganglia, mostly putamen out here, is getting harder to see. And there's just a little bit of the caudate, but you may not be able to recognize it. And what I want you to see is this sort of grayish-black smudge here. This is the substantia nigra that's going to play an important part in our discussion. And you can see that it's actually moving down. It's going to be also seen together with the cerebral peduncle. And I can imagine and see, but I don't know if you can, there is a little nucleus out here, just sort of above and a little bit lateral to the substantia nigra called the subthalamic nucleus. And that's also going to be part of our discussion. Now let's look at the substantia nigra for a moment before we go to the circuitry. So now we're looking at the ventral surface of the brain stem. This is the medulla, this is the midbrain, the cerebellar hemisphere is out here, and I'm going to turn this so that you can see the rostral part of the brainstem, which is the midbrain. You recognize the aqueduct, the cerebral peduncles, and here we have the black substantia nigra. So this part that is filled with dopamine cells, which can degenerate and cause basal ganglia disease, is an important component of today's instruction. Let's quickly just look at these same structures in an axial section. So now we have an axial section where I'm going to point out some of these same structures. Up top here we have the frontal pole, and back here the occipital pole of the brain. And we have the ventricular system. This was back in the occipital horn. Here is the frontal horn. And here are our caudate nuclei, separated from the putamen out here by the internal capsule. So caudate, internal capsule, putamen. Then this pale area is the globus pallidus. And on this side, a pallidus can be seen to be divided into two parts. At least I can see it. There's an external part and an internal part to the globus pallidus. And then this is the internal capsule. And the thalamus is starting to blend into the midbrain. Let's look at one more section a little bit lower, or ventral. This section is a bit asymmetric, but it shows us what we want to see. Here again is the frontal lobe, the occipital lobe, part of the ventricular system. And right here in the middle is our midbrain. You can see how it sits right in there with the mammillary bodies and the hypothalamus and the optic tract right around it. And again, now you can see the substantia nigra, this black substance, right between the cerebral peduncles and the rest of the midbrain. There is an area that you can't really see very well, right about in between the substantia nigra and the level of the midbrain, called the ventral tegmental tract. It, like the substantia nigra, is filled with dopamine-containing cells, but these in the ventral tegmental area project up to that ventral area of the striatum, the nucleus accumbens. Now, let's look at the circuitry using a computer diagram. So now we're about to tackle the hard part of this, and we're going to do it in the simplest form I know how, with some excellent diagrams from my colleague Stephen Voron. So let's look at the structures that we've already identified on the gross section. The striatum, which would be your caudate and putamen, the globus pallidus, which is the pallidum, the thalamus, which I showed you on the large model, the cerebral cortex, which we're already acquainted with, and the midbrain with the substantia nigra and the ventral tegmental area in between. So we have two circuits. The first circuit is the cortex to cortex circuit. So remember, this is a consulting loop. So the cortex is consulting the basal ganglia in order to improve movement. So cortex to striatum to globus pallidum to thalamus to cortex, right? And then the cortical spinal tract comes down, remember our motor pathway, all the way down, crosses at the top of the spinal cord, and becomes the cortical spinal tract in the spinal cord, and that is the way all movements are basically executed on a voluntary basis. The second loop involves the substantia nigra, the pars compacta, as it's called. We'll just call it the nigra. And it also involves the ventral tegmental area. But let's just talk about the nigra. And it projects with dopamine, a dopamine pathway called the nigrostriatal pathway, using dopamine, right? And that is the other pathway. It is these nigral cells that tend to degenerate in Parkinson's disease. Now, let's add another level of complexity to this same diagram. Here are three main points I want you to remember when we talk about the basal ganglia. First is this cortex-to-cortex circuit, and I'm going to show you in a minute there are actually two parallel circuits. This substantia nigra dopamine circuit, and I want you to remember now that the signs and symptoms of basal ganglia disease are on the opposite side because they influence the cortical spinal tract. So basal ganglia signs are expressed on the opposite side of the body due to the pyramidal or cortical spinal tract that they influence as it descends. Now let's make this circuitry over here a little bit more complicated. So now the story gets a little more complicated when we look at the trajectory of these dopamine-containing cells in the substantia nigra that project to the striatum, in this case the putamen, which is quite involved with motor activity. We have a light and a dark pathway, and they represent excitation and inhibition in this case. And that is to say that dopamine, the transmitter, has two opposite effects on these D1 and D2 cells in the striatum. In one case, the transmitter is excitatory to certain neurons, and in another case, it's inhibitory to other neurons. In addition, we also have acetylcholine in some of the neurons in the striatum, and they also have different effects and opposing effects on these cells in the striatum. So this leads to the idea that we have two pathways, a direct and an indirect pathway to the globus pallidus. This is the globus pallidus, the internal part of it. And here we have in this indirect pathway another station or another synapse, not only with the outer part of the globus pallidus, but with that subthalamus, and then onto the globus pallidus, internal part. So we have a direct and an indirect pathway. And then from the globus pallidus, most of these neurons going to the thalamus inhibit the thalamus. That is to say, the thalamus is normally inhibiting the cortex, keeping extraneous movements from occurring. And only if you have the right combination of direct and indirect stimulation do you get the decrease in the inhibition, which allows the increase in the excitation and for the action to be carried out by the cortex. Now, don't sit there and fret about, is this inhibitory, excitatory? There are just two things that you need to remember. That the indirect pathway is usually inhibitory to movement, and the direct pathway facilitates movement. All right? The indirect inhibits, and the direct facilitates movements. And these both act through the thalamus to the cortex. So that's not so difficult. Now let's look at certain diseases. You might expect, and this is what we see, that if you interrupt a pathway that is inhibitory, the patient ends up with too much movement or hyperkinesia. And if you interrupt a pathway that is facilitatory or excitatory, you might end up with not enough movement or hypokinesias. So we have a whole variety of movement disorders that have combinations or primarily too much or too little movement. And so now what I'd like to do is to move on to the videos I have giving you some examples of hypo and hyperkinesia. Along with this, changes in muscle tone occur. Basal ganglia disease is associated with rigidity. This is something you cannot show in a movie, but you certainly can feel it when manipulating the patient. Now let's look at some examples of Parkinson's disease, beginning with a pathological picture of what the midbrain looks like in patients with severe and late-stage Parkinson's disease. This pathological picture compares a normal midbrain with the midbrain of a patient with a severe end-stage Parkinson's disease. The most striking feature is the melanin black pigment, is absent in the midbrain of the patient, and melanin is a precursor to the production of dopamine. I can also point out to you this ventral tegmental area between the two cerebral peduncles, and recall this is a dopamine projection, not to the striatum that we've looked at before, but to the ventral striatum and the nucleus accumbens, which is just loaded with dopamine receptors, is involved with eating, sex, drugs, nicotine, and is a very important pathway associated with emotion and the limbic system, as well as reward in a behavioral sense. So this is a very important pathway, but difficult to show you. But much literature deals with this pathway as part of the limbic system. This Parkinson's disease patient has a resting tremor in his right arm greater than his left arm. And when he is asked to raise his arms above his head, notice that the tremor in his right arm decreases remarkably. This is basically the opposite of cerebellar disease. And notice now on the finger to nose test, his accuracy is quite good. He's a bit slow because it's a little bit rigid and stiff, but he does fine and doesn't have a tremor. This is a different patient with Parkinson's disease. You'll notice that the resting tremor in his arm, he's not asked to use his arms, he's using his legs. This resting tremor is a typical 4 to 8 cycle frequency per second tremor. And notice his legs. When he turns, he takes 2 or 3 steps. He doesn't just swivel 180 degrees on one foot. Look at his face. And you notice his face, he has very little expression. He doesn't blink very often. And that goes along with the paucity of movements that these patients have. And he's quite rigid, but we can't assess that in this short clip because we cannot manipulate his arms or legs. This woman is asked to, as quickly as possible, put her finger and thumb together repeatedly. And you'll notice that she's a little slower on her right side, but much slower and lower amplitude on her left side, which is more affected with rigidity and decreased ability to execute rapid movements. They're not as high in amplitude or as quick as they should be in a normal person. Previous examples of bradykinesia, or too slow movement, or decreased movement, were associated together with the tremor with Parkinson's disease. But now I want to show you examples of hyperkinesia, too much movement. This gentleman at rest has writhing fingers in sort of a sinusoidal movement called athetosis. He's asked not to move his hand, but he cannot prevent it. This is mild in this gentleman, and it can be due to a whole number of things. One of them is anoxia. Another cause can be due to, let's say, a stroke in the thalamus, or even high bilirubin as jaundice in a neonatal. It's also a precursor to Huntington's disease in many cases, and I'm going to show you next a more advanced stage of Huntington's disease. Athetosis is the more distal part of the extremities. Here is an example of Huntington's disease and choreiform movements, big, broad, jerky movements of all parts of the body. And unfortunately, this is also accompanied with major subcortical dementia. This is a postmortem specimen from a patient who died of Huntington's disease. This disease involves degeneration of the neurons in the caudate nucleus, which is a mere remnant in this image. And in turn, the ventricles have enlarged. Recall that before, the caudate bulged very large into the lateral ventricle. It's totally gone. In addition, the putamen is smaller, and accompanying these wild movement disorders is a dementia, a very severe dementia that is called subcortical dementia, and it's part of this very severe autosomal dominant disease, which does not manifest itself in most patients until they have reached their childbearing years or even slightly beyond that. So early diagnosis is important together with counseling. Another movement disorder of the hyperkinesic type is myoclonus. This young gentleman has had an infection. So this is the result of an infection, post-infectious myoclonus. Now, he's trying to do the finger-to-nose test, and as he concentrates on that, his body makes these wild jerks that interrupt it. So it's not that he's got a cerebellar problem. He could complete it if his body didn't jerk on him all the time. If it doesn't jerk, then he's able to complete it. These myoclonic twitches or jerks can be due not only to an infection, but they can come with head injuries, strokes, brain tumors, kidney or liver failure, and chemical or drug poisoning, among many, many disorders. So myoclonic jerks, like you just see here, is typical of a variety of etiologies. And one of the more common etiologies is severe hypoxia. So you may see something called post-hypoxic myoclonus. Phew, that was a lot, wasn't it? Pretty difficult. And I know you can't remember it all right away. If you can only keep a few things in mind, think of the patient symptoms and signs that you looked at. And remember that those signs and symptoms from the left half of the basal ganglia are going to be expressed on the right side of the body because the cortical spinal tract comes down and crosses to the other side and influences the spinal cord. Also remember that if the cortical spinal tract is damaged, then you won't be able to see these basal ganglia subtleties of movement because the cortical spinal tract damage will overwhelm, if it's severe, the expression of these basal ganglia diseases. And also remember that the basal ganglia work with the cerebellum. Both of them are consultants to this cortical spinal tract. And you need to only try to sort out if your diseases are cerebellar in signs and symptoms, basal ganglia in signs and symptoms, or cortical spinal. If you only have those three sort of bins to put the signs and symptoms in, you'll be a long way to achieving neurological localization, which is our goal.